My name is Dan Ferris. I'm the Assistant Director of Policy and External Affairs at the McSilver Institute at NYU and part of the MCTAC team. I'm joined today, not physically, but also on the webinar by my colleagues Yvette Kelly and Caitlin Cronin. And we're really excited to be offering part 2 of a 2-part series on children's home and community-based services. Part 1 was offered on Wednesday. I'm sure many of the folks on the line today were with us for that as well. If you weren't, the slides are currently available and a recording is being posted shortly. Slide for today, a link has been posted in the chat box on the right-hand side of the screen. If you're looking at the upper right-hand corner, you can click the little chat bubble and that box will open up. So you can take a look at those. You can also just go to ctacny.org and mctac.org. They both will direct you to the same place. And under recent trainings, this should be the first one on the list. And you can also use the very handy search widget, which I know folks have been enjoying since it debuted just a month or 2 ago. So today's presentation, we're joined again by Angela Keller from New York State Office of Mental Health to talk about home and community-based services, timeline and transformation efforts. Meredith Ray-Labatt from OMH will talk about habilitative skill building and customized goods and services. And then we're joined today by a few friends and colleagues at the Department of Health, Cynthia Jackson, Linda Milano, and Alyssa Sleesback, who will be both presenting and taking questions on adaptive and assistive equipment, palliative care, accessibility modification, and non-medical transportation. So quite a few things to get to today. So we're very excited to jump right in. And with that, we're going to talk about housekeeping and logistics. So just really quickly, I mentioned the chat bar on the side. Please do send us in your questions throughout the presentation. We collect them and we do our best to get them organized, minimize duplication so we can make the most and maximize the time that we do have set aside for Q&A at the end. Questions not addressed today will be reviewed and incorporated into any future trainings and resources, including Q&A documents that we put together in partnership with our partners at the state. And as I mentioned, the slides are already posted, and a recording will be available soon, if possible, later today. It's our goal to at least have it out in the TAC Weekly Digest, which comes to your email inboxes on Monday mornings. So keep an eye out for links for that. And then just as a reminder, if you're listening to a recording of this sometime in the future, either next week or 5 years from now or something, that the information and timelines are current as of today's date. And that the content that's being presented today is some summary and some context around what will be made available in a draft HCBS manual that will soon be made available and distributed online. So the goals for today, very similar to the goals from Wednesday. So take a little bit of time explaining children's HCBS. So again, if you were with us on Wednesday, this will be a little bit of a refresher. But I know Angela's got some tricks up her sleeve to keep people engaged and interested. And then also we'll be looking to inform service providers' decision-making process about obtaining HCBS designation. So again, the designation process is not quite finalized and live, but we're hoping to have updates about that in the coming days and weeks. And just again, the agenda for today, I mentioned our presenters. There'll be a general update, a walkthrough, high-level overview of the services. I'll come back on towards the end to just talk quickly about future training and available resources, and then we'll launch right into Q&A. So with that, I will turn it over to Angela Keller to give us an overview of children's home and community-based services.
Hi, good morning, everyone. So what I wanted to start off with before we turn it over to the service-specific overview is really talk about the timeline. The timeline was announced last Thursday at the MRT meeting, Children's MRT meeting, Medicaid redesign team. And Dan, could you go to the next slide?
Did they give it to us?
Sorry, give me 1 second. I changed who has the ball.
Oh, I got it. It's working today.
Oh, fantastic.
Okay. So sorry about that, folks. So we wanted to announce and remind people that if you hadn't heard the news, that there's been some changes to the timeline. So we were anticipating on January 1st of next year that all 6 of the new state plan services would begin implementation, and we have made some alterations to that. Instead of 1 state plan amendment that's going to CMS, we've split that into 2. So the first service, Other Licensed Practitioner, will begin in fee-for-service statewide on March 1st, 2017. As you see from this timeline, for October 1st of 2017, a number of things will happen. So the 1915C care coordination will transition to Health Home for New York City, Nassau, Suffolk, and Westchester counties. The 5 remaining state plan services will be implemented statewide in the fee-for-service system. And then all of the HCBS services and some of the existing Medicaid behavioral health services, including the 6 new SPA services, will be carved into Medicaid managed care, also in New York City, Nassau, Suffolk, and Westchester counties. And then children who are in receipt of HCBS will be mandatorily enrolled in Medicaid managed care. So that date moved from July to October. Then if you look at the timeline for the dates in 2018 and 19, these dates have not changed, and what is happening in each of those time frames is still the same. So January 28th will be the rest of the state transition that I just reviewed. July of 2018 will be when the expansion of the level of need group, community eligible, are offered the expanded HCBS and SPA services. These are folks that are eligible for Medicaid due to their family's income, so they're already in the Medicaid system. And then on January 1st, 2019 is when we will expand the level of need expansion group to include children that can become Medicaid eligible as a family of 1. And the other major change, as you see on the last bullet for January 1st of 2019, is that the mandatory enrollment of the voluntary foster care population moving to managed care has changed to January 1st, 2019.
If the slides aren't advancing, Caitlin, do you want to pass me back the ball? All right. Yeah. We had luck with 1, but one day the slides will advance. That day will not be today. Oh. All right. Here we go. Dan. Of course. So one of the things we wanted to remind people, and we reviewed on Wednesday, is that the existing 1915C HCBS waivers, so the OMH SED waiver, the OCFS Bridges to Health waiver, and the Care at Home 1 and 2 waiver, we are aligning all the services across those 5 waivers so that all populations that meet either level of care or level of need criteria can have access to these service arrays. So what we have here and on the next slide is that across the top is what the services will be called in the new transition, and in yellow is just to indicate where the existing foundation came from. So for example, habilitation, the foundation of that service is in the OCFS B2H waiver. And as you see with respite, that was in common across the 5 waivers, et cetera. So on the next slide is the remaining 5 services, and that is what we will be focusing on today. And as you see, non-medical transportation did not come from one of the existing waivers, but is a service that was in the 1115 on the adult side, but we will get to that later. So today's update will be on, as I said, these remaining services in the HCBS service array. We are highly optimistic that next week we will release the designation application for providers to apply for designation for both the SPA services, the new SPA services, and HCBS, that will happen next week.
With that release will also come the release of the HCBS Provider Manual, and this is the first time we've released that draft, and we will re-release the SPA Provider Manual, which has been revised since our last public release. One of the things that we discovered on Wednesday was, because of all the transitions of different groups of children, services, the timeline is confusing because there are multiple things that occur, is that we just wanted to remind people that the carve-in to Medicaid managed care starts on October 1st, 2017 for downstate and January 1st of 2018 for upstate. The implementation of health homes starting in December, and as I said, the implementation of the new SPA services in 2017 will go as defined on the timeline. So really the goals we were trying to achieve with the alignment and retention of the existing HCBS services was to offer supports and services to children in non-institutionalized settings and in the least restrictive settings, that it would allow the child to remain at home and in their community with the availability of these services that can be wrapped around the children and their families. It would be integrated, recovery-oriented, person-centered care through a single plan of care, and that care will evolve over time through the ongoing coordination, which in the case of children will be conducted by health homes serving children, and that we also support through this implementation the integration of trauma-informed care into the delivery of all the services. So next week, again, we are highly optimistic about this release, that when the HCBS Provider Manual goes out, these are the sections that will be in the manual. There will be a definition of each of the services. What are the service components for each one? Modality, setting, agency, individual and supervisor qualifications, and training requirements. There will, in a future revision, be limitations and exclusions, but that section will not be released when this first draft is released. And as the rest of my colleagues get to going through each of the services, we will cover most of those categories. One of the things we also want to remind people, as you read through the provider designation application, the provider manuals, we will talk more about this, but we have upcoming webinars that will be announced to assist providers that are not Medicaid providers today to become Medicaid providers, as well as a webinar on the SPA and HCBS rates and the methodology. These will be draft rates, but we wanted to provide all of this information to really guide people in their decision-making on whether to apply to be designated for one or more of all of these services. One thing to keep in mind with the provision of HCBS services is CMS released a final rule which specified that there are certain settings in which HCBS can be provided and also where the HCBS recipients must live. In general, it needs to be in the community where the individuals have choice, they have ensured their rights of privacy, dignity, and respect, they are independent in their decision-making, and that choice is facilitated across the services. And the final rule stipulates additional requirements for some of the services, and we'll have a lot of guidance forthcoming in the future as we get closer to implementation. But for example, if a service is delivered on site of an inpatient setting, that is not allowed under the HCBS settings rule unless it is an emergency service such as crisis respite. And if an individual is living in an institutional setting, they cannot receive HCBS. But again, we will get clearer about those nuances as we get closer to implementation. So now I'm going to turn it over to Meredith Ray-Labatt to begin some of the service overview.
Thank you, Angela. Okay, so we're going to start with habilitative skill building. Great. All right, good. Thank you. Habilitative skill building is a service that is currently available in most of the waivers today, at least the OMH waiver and the B2H waiver. And what it really allows providers to do is to focus on helping the child be successful in the community. These are HCBS services, so we're maintaining children and families in the community. The large difference between this service and, let's say, something like psychosocial rehabilitation in the state plan service is that this is intended to be a service that assumes that the child has never had the skills acquired prior. So unlike rehabilitative skill building, this is habilitative skill building. So it's based on the assumption that you're developing a skill that is not present and that has never been present with the child. So that's the differentiation between those services. If we can move on, we'll give some components and some examples. So the service is intended to do a variety of things and to support the child's development of such skills. And these are a wide variety of examples, things such as socialization skills, communication skills, organization, money management, use of transportation, things that the child has never yet mastered before, and of course whatever is in accordance with their at the time of their development and what they need to learn to be successful to function in the community, in their home and in their school, and at some points in time, obviously also to prepare for their transition into adulthood and to prepare to start taking on more of an independent role in their community. And so that would also assist in their development of some adult-type skill sets as they age out of the children's system as well. So it's intended to be appropriate for the entire age array, and the skills could be applied as needed based on where they are developmentally. We can move to the next slide. The allowable service modalities are obviously the individual face-to-face intervention where the skill builder would be working one-on-one with the young person. It's also allowable in a group face-to-face intervention with no more than 2 children or families. So these skills could be worked on together with more than 1 child, or it could be worked on with a child and their family or families in those circumstances where appropriate. As far as the qualifications of the staff and the provider agencies, so as with most of our HCBS services, this is standard language that you've probably seen multiple times, which is any child serving agency or agencies with child behavioral health and health experience that's licensed, certified, or designated by DOH, OMH, or OASIS, or in the case of the voluntary foster care agencies, licensed or approved by OCFS to provide a comparable and appropriate service. So that's a standard with most of these services that you'll be seeing in the HCBS service array. It's obviously also not-for-profit skill-building agencies. The staff themselves, the minimum qualifications, again, the minimum is that you would require a high school diploma or a high school equivalency degree with related human service experience. And of course, as always, it's preferred that the person has experience working with children. And then similarly, for a supervisor, the minimum would be the bachelor's degree with 1 year's experience in human services, also working with children and families. Of course, preferred would be 2 years' experience in a human services field. So all this information and the specificity of the qualifications of the providers and of the individuals are also available in the draft HCBS provider manual that will be issued shortly. Great. Excuse me. The next service that I'm just going to be touching on really is called customized goods and services. And customized goods and services is similar to what most folks should know as kind of flexible service dollars today. In the Office of Mental Health programs such as the HCBS waiver and our TCM programs, our care management programs, we have what's called flexible service dollars that are available for the use in those programs. And the intent of customized goods and services, or in the case of flexible service dollars, is really to allow for accessing of services and items that would not normally be accessible to the individuals, who is directly tied to their treatment plan and the achievement of their goals and objectives, and is not available by any other means. And so what we're doing in the children's side is mirroring what the adults are doing in their 1115 self-directed care pilot. So we also will be doing a customized goods and services pilot. Of course, the adult side is still pending final CMS approval. So what that would facilitate is the use of a fiscal intermediary to help manage budgets and process the goods and services for payments. So we're considering using that also for the children's pilot. There will be an annualized dollar amount per child, a cap on how much money would be available per child. And again, as I stated previously, these customized goods and services are really items or services that can be purchased to benefit the individual based on their individualized service plan. But this service or this money is only available to, as a last resort when no other type of service or resource is available in the community to access it, and it's only for those children who are receiving HCBS services who have an approved plan of care and whose family income does not exceed 150% of the poverty level. So if we move on to utilization, this just again provides language around what I've talked about, is that it really is considered a last resort. It's intended to be focused on really helping the child and family access things that would not normally be available to them, and is directly tied to the goals and objectives identified in the individualized service plan, and they're part of the service plan. And again, it's only to be used if there's no alternate resource available in the community that one could access through, let's say, the Department of Social Services or through other available community charity means. So it's a last resort, but it allows for accessing of things that would not normally be accessible for individuals who are HCBS enrolled. So those are the two services that I wanted to touch on. I'm going to pass it over to Linda Milano, who is with the Department of Health from the Care at Home program.
Hi, this is Linda. I'm going to start out with the adaptive assistive equipment. In this new single children's array of home and community-based services, adaptive and assistive equipment is going to include additional equipment that is not available to children in the Care at Home 1 and 2 waiver program. This will be beneficial for these children. Adaptive and assistive equipment provides technological aids and devices that can be added to the home, vehicle, or a child's residence to assist the child in their daily tasks. These technological aids and devices assist the child in their ability to safely function with independence in the home and community-based setting. The adaptive assistive equipment available through the home and community-based services, though, cannot duplicate equipment otherwise available in a Medicaid state plan or state or federal funding streams. And there will be more information and guidance to be forthcoming on this service. Now I'm going to speak about palliative care. The Care at Home 1 and 2 waiver program offers palliative care services designed to meet the needs of a child and their family by addressing end-of-life issues related to their illness. In this new array of home and community-based services, the palliative care services has been revised to remove end-of-life treatment in order to open up these services. In addition, the Family Palliative Care Education Service, that was a service under the palliative care, has been moved to the service here, but is maintained under the Caregiver Family and Support Services. Palliative care is defined as a specialized care focused on providing relief from the symptoms and stress of a chronic condition or life-threatening illness with the goal to improve the quality of life for both the child and the family or caregiver. It can be provided along with curative treatment. These services are provided by specially trained staff who will work together with the child's doctors to provide an extra layer of support. The palliative care service components are pain and symptom management, bereavement services, massage therapy, and expressive therapy. Pain and management provides relief and or control of the child suffering related to their illness or chronic condition. Bereavement services will assist the child and their families to cope with the grief that's related and part of their illness or condition. Massage therapy will aim to improve muscle tone, circulation, range of motion, and it will address physical symptoms related to the child's illness or chronic condition. Expressive therapy is the use of art, music, and play to assist the child to better understand and express their reactions that come about from their illness and their chronic conditions. Palliative care services are provided by a certified home health agency or a hospice agency, and the individual staff qualifications will depend on the palliative care service that you are providing. The full list of eligible individuals to provide service and training requirements is going to be outlined in the draft Home and Community-Based Services Provider Manual. Accessibility, I'm going to go on and speak about accessibility modifications. These are modifications that are provided for a child for their home or another waiver eligible residence that's necessary to support the health, welfare, and safety of the child and enable the child to function with greater independence and to prevent medical institutionalization. These modifications are additive to services that are available through a Medicaid state plan or another state or federal funding streams. And there will be more information and guidance to be forthcoming on this one. I'm going to turn it over to Alyssa.
So non-medical transportation. Non-medical transportation is actually going to be a new service. Unlike some of the other services, this is not transitioning from one of the existing 1915C waivers. Non-medical transportation is going to be available for services and destinations that aren't typically covered under Medicaid medical transportation, which currently covers trips to state plan services. So there are two types of non-medical transportation. The first is transportation to and from the HCBS that a child or youth is receiving. So if an individual actually does need to go on site for an HCBS, although we expect that much of the HCBS will happen in the child's home or community, transportation could be covered for some of those trips. And then it would also cover trips to destinations that are directly related to a goal in the child or youth plan of care. So if anybody is familiar with the adult non-medical transportation available to eligible HARP enrollees, this is going to very closely follow that service. So for example, if somebody needed a trip to a non-routine, GED prep class or a wellness seminar, job interview, things like that, that are directly tied to a goal in their plan of care. So if their goal is to obtain employment and they wanted a trip to a job interview, non-medical transportation could be utilized for that. Non-medical transportation, there's going to be a lot more guidance coming out to see what the adults are currently doing. I think there's some links in the next slide. It's going to be very similar to that. In terms of who can provide this service, you do have to be a Medicaid transportation provider. So if you're not enrolled as a transportation provider, the link to do that is right on this slide. I think that's it for non-medical transportation at this time. More guidance will be forthcoming.
Great. Thanks so much, Alyssa and Linda, Angela, and Meredith. That was really, really great. So just a really quick overview of some training and resources. Again, just recognizing that at least a few of the folks who are on today were likely on Wednesday, so I'll keep this brief. But so this is just to say and outline that support and information will be available throughout the designation process, as Angela mentioned, which is upcoming. And then also as system transformation, both around SPA, HCBS, and managed care specifically for the children's system moves forward. MCTAC will be along every step of the way and offering tailored, developed trainings and resources similar to the approach on the adult side, but of course keeping in mind some of the nuances and specific needs that children's providers have, looking all the way back to, if folks on the phone remember, the children's specific readiness assessments and addendums We had some great lessons learned and some takeaways from that, and keeping those things in mind to help support folks as best as we're able around some of these exciting transformation efforts. Again, just going to leave this slide up for a second because we know that it's usually as soon as we wrap up the webinar that really amazing question comes to mind. Not to say that the questions we're not getting right now were amazing, but we're all familiar with that feeling. So here's a few of the places based on who you work with at the state level that you can send your questions in. Also, the one that we always like to point people to is mictac.info@nyu.edu, which you should have in your event confirmations, and also you are linked to from the MCTAC website. And then these are just a couple of resources that we know that we like to follow and keep on top of. And so we'd suggest that folks on the line, if you're not already, and we suspect many of you are, to stay informed by subscribing to the Children's Managed Care Listserv, the DOH Health Home Listserv, and others that are out there. And so with that, again, we would just encourage people to visit mictac.org to view past trainings. Again, in terms of the slides for today, they are already live on the website, and we'll be sending around on Monday links to the slides, as well as hopefully recordings from parts 1 and 2 of this series as part of the weekly TAC digest. So please keep an eye out on your inboxes for that. And with that, that is the end of our formal slide presentation. So we're going to encourage our partners on the state side to take their lines off mute if they've done so in the background. And we're just going to start going through some of the questions. So if folks give us just 1 second to pull these up. And Angela, I don't know if you have the copy that circulated around via email as well.
Yes, thank you, Dan. We can see the questions, and if people can bear with us, the state partners are not physically in the same location, so we will punt some of these questions back and forth. One question that was asked, are children going to be HARP eligible? Great question. One of the big differences between the children's design and the adult's design for the transition to managed care is that there is no HARP product for children. The benefits that we discussed through Wednesday's webinar and today's, in addition to the new SPA services, which are available in more detail on webinars on the MCTAC website from previous presentations, all of those will be in the mainstream Medicaid managed care plans, not be in a separate product line. So there are some differences in terms of people as they've become familiar with HARPs and what that allows them. It's a different set of services, slightly different process, and certainly different target population.
What does HARP stand for?
And HARP, for those of you that may not know, stands for
Health and Recovery Plan. Yeah?
Okay. So,
is that correct?
Alyssa, I see a couple of questions on the non-Medicaid, non-medical transportation. Are those ones that you can answer?
Sure, I'm just trying to find them here. So the first one is, if a goal includes medical appointments, foster care visits, et cetera, would this be included under non-medical transportation? So for the first point of that, medical appointments, if they are state plan Medicaid services, the transportation would already be covered under Medicaid today. Foster care visits, that would be something that would have to be determined based on what the goal is that trip was supporting. So the important thing to remember about non-medical transportation is that the trip has to be very directly tied to the goal. And so I think it'll become a little bit more clear when the guidance comes out, and in the meantime, if folks want to refer to the adult guidance, I think that would be helpful to help understand the types of trips that would be included, but we will certainly have more guidance about that in the future. And then what's the other one? For non-medical transportation, can this be used to transport elderly guardians to attend family therapy with their grandson enrolled in a waiver? So non-medical transportation is transportation for the actual Medicaid enrollee who is HCBS eligible. So in this case, unless that guardian was attending family therapy with them, then the transportation couldn't be used solely for that guardian. In this case, family therapy, again, it would have to be clear that that was, a non-routine trip that was directly tied to a goal in their plan of care. If that is an actual HCBS service, then if the child was having to go on site for that appointment and their guardian was going with them, then that would definitely be covered. I think, typically in the Medicaid transportation world, children especially are allowed to have somebody accompany them on the trip. Unless I'm missing it, I think that was it for non-medical transportation services, so we could. Oh, will parents or others be able to use non-medical transportation? The answer is yes. They can go with the child. They just can't use the service themselves if they're meeting up with a child or something like the other question was suggesting.
Okay. Thanks, Alyssa. Another question is, what is planned for children whose families are earning over the poverty requirement? I think this question, I'm assuming, relates to the current 1915C waivers where children who are level of care eligible or meet that criteria can then apply for Medicaid and be considered as a family of one. That is being maintained for the level of care as we move into managed care. And for children who meet the new expansion group of level of need, we also are including a request to CMS that family of one be one of those groups that can get Medicaid without regard to their parental income. If that's not the question the person was asking, please type in an additional question in the chat box.
There is a question about please explain the difference between habilitation and habilitative skill building. Habilitation, again, I wasn't part of the last presentation, and I know that that was a service that was reviewed. So for more information, certainly you can view the recording of the previous Wednesday's session, or also read further in the draft HCBS provider manual when it's made available. But habilitation, currently today, is often known as day habilitation, and is often provided through providers who work with the OPWDD population and work intensively with individuals through rehabilitation services. Habilitative skill building is a little more broad and can be addressing any wide variety of skills that a child may need to develop associated with where they are developmentally or where they are clinically or where they are medically. So it could be one-on-one and an individual working with somebody to develop a skill set. So it's a small nuance of the differences in who can provide it, how it's provided, where it's provided is the nuanced differences between the two services.
One of the questions was whether we can explain the timeline for when rates will be set and how they will be established. Will all providers have the same rates for HCBS and SPA? Will initial billing be all straight New York State Medicaid for kids in foster care till 1/1/19? I'm going to pull that apart a little bit. So we have drafted rates that will go with the various applications we file with CMS. As with the services we've described here and in the previous SPA webinars, all of that will be teased out through negotiation with CMS. There could be revisions to provider manuals as a result of those conversations. So the rates that we have drafted at this point and we'll share in the next several weeks with publicly are draft. They're just to give folks an idea of our thinking on rates to inform decision making around applying for designation. The The other piece just to point out is similarly with the kids design as with the adults, there will be certain protections in place for providers, such as the government rates will be required for the first 2 years for HCBS, SPA, and also behavioral health services that are transitioning to managed care. And the question, will all providers have the same rates for HCBS and SPA services? All providers, regardless of whether you're today a foster care provider, mental health provider, substance use provider, or medically fragile provider, everybody's rates will be the same for each of the HCBS services and the SPA services. So everyone will be paid the same, assuming you meet the qualifications and are designated. For the transition of children in foster care, how will the initial billing be paid? There will be more information forthcoming from OCFS regarding that transition. Unfortunately, OCFS staff were in other meetings today, so they couldn't be on the phone with us. So we will make sure to get that question answered and provide a Q&A on both webinars on MCTEC's website. So another question is requesting an update on the state plan amendment, the SPA. The SPA, now 2 SPAs as we talked about with the timeline, are making their way through the DOB, Division of Budget, the Governor's Office, and Department of Health approval process to be released to CMS. Another question will be clarified in the SPA manual what type of license programs would be eligible to provide the specific SPA services. Yes, just as we did today and Wednesday, for each service, there are requirements for the provider agency, the individual practitioner, and the supervisor to provide each of the services. Some of them are the same, some are different. But that is all spelled out in the SPA manual, which will be re-released. There is a current version on the DOH Children's Managed Care website, which was on, I believe, the second to last slide of this deck. And it was a March 2016 version that is posted, so that gives you some sense, but certainly there have been some revisions since that time. And there are other questions that people have typed in that we may not have answers for, and we will have to take back to other experts that are not on the phone to make sure that we answer them comprehensively. So if we've not addressed your questions, we still have them, and we'll certainly get the answers and get that posted.
Great. Thanks for mentioning that, Angela. And I would just chime in quickly that with some of the other presentations and supports that are ongoing during the designation process, it would be our full intention to address as many as we can, both during future presentations as well as possible Q&A docs and others that we'll work to put together to make sure that the great information that's being covered today is available to everyone, whether they were on the webinar or not. So. If you guys wanted to do one last pause just to see if there are any last questions. And then
I think one thing I'll just mention to everyone that as the provider designation application is released along with the manuals, we really encourage all providers out there serving children and even those providers that are providing HCBS to adults to really consider applying to be designated for one or more of the services. We have built the design and the foundation on some of the children's services that exist out there, and we know that we have a workforce and agencies that are already providing some of these. So we certainly hope that you all will come forward and asked to be designated, and there will be many more details to come on the designation through webinars to be announced shortly.
Fantastic. Well, I would just like to take the chance to thank our partners, especially today at OMH and DOH, for doing a real heavy lift walking folks through the remaining HCBS services. This has been a great two-part series, and as we've mentioned, we hope and anticipate shortly, imminently, to have information out about the designation process, and we'll be getting something on everyone's calendars about that soon. So thanks again to all the presenters, and we look forward to getting back together to talk more about home and community-based services for kids very soon. Happy Friday all, enjoy the weekend, and see you next time.